panels. I think, good morning, everyone. Welcome to this, what sounds like it's going to be a very interesting discussion on the airway.
Okay.
And so Dr. Raveendra and Dr. Suma. Is Suma here?
Suma is there. Dr. Suma? Come. 4 chairs.
I'm obviously biased because both Dr. Raveendra and Dr. Sumalata worked with me as colleagues and students many years ago. And so go ahead with your panel discussion. Now, where would you like your panelists to sit?
I think they can sit here facing the audience.
So we'll have them in the center. Yeah. So could we have the chairs brought here in front?
Yeah, they will bring. Okay, as we get the things arranged, good morning to everybody. At the outset, I would like to express my thanks and gratitude to the organizing committee for putting up such a wonderful and very highly effective and useful academic program. And I feel honored by the presence of Professor Elsa Varghese and madams as our chairpersons for this occasion. For this panel discussion, we have an esteemed panel of the panelists who are eminent pediatric anesthesiologists with vast experience behind them and with lot of teaching experience. Those are the people whom we look at as our mentors many times.
We'll be introducing the panel.
Our panelists are okay. Our panelists are Dr. Prabhavati Kaza, Dr. Dilip Pawar, Dr. Serpil Ozgen, and Dr. Josephine Tan, and Dr. Deepak Srivastav, and Dr.
Dr. Madhankumar Sathyamoorthy and Dr. Diganta Saikia. So do we have everyone? Yes. We have, it's really a very interesting panel from across the board.
Yeah.
There are only 2 there. So Josephine, would you like to go across? We have some more women power that side.
One of you can come
You
here.
can sit here. You know, this is not boys against
Thank you for
girls.
balancing the equation.
So shall we get going?
Yes, please go.
Okay, for this panel discussion, we have put together 3 cases or 3 patients, I would say. All of them having different kinds of difficult airway. And we'll be spending 15 minutes on each case so that we will not be leaving behind any one of them and trying to cover different aspects of the difficult airway management applicable to pediatric patients. So to begin with, we are just putting a slide on our All India Difficult Airway Guidelines on Unanticipated Difficult Intubation in Children, which was recently published and accepted widely. That was 2016. It was published in our Indian Journal of Anesthesia. This forms the background. Probably this is something which we can take always. Anything what we discuss can be within the limits of these guidelines. The first patient, the presentation will be like this. We'll be asking the panelists the different questions about the management, involve the audience. If anybody wants to add any important point, they can just raise their hands and probably give their inputs also. Towards the end, we will summarize and move on to the second case. So now our first patient is a 2-day-old baby with Pierre-Robin syndrome, which we are all worried about always as pediatric anesthesia, especially when we do the pediatric patients occasionally, not very frequently. Those who are regularly anesthetizing a child will not have much problem most of the time. But if you look at further, this child with severe upper airway obstruction, a 2-day-old baby with Pierre-Robin syndrome, severe upper airway obstruction, has small bowel obstruction added to the problems and presents for laparotomy. So obviously quite a complex scenario. So we will get going and start with Dr. Madhankumar. So he is the one who has managed this patient. So we'll begin with him. Dr. Madhankumar, This patient is quite a difficult one for most of us. So how do you begin with what are the anesthetic concerns in this patient, particularly with reference to airway? We are not going to much details about the other parts, our focus on the airway.
Yes, this is a newborn with the diagnosis of Pierre Robin with all the characteristics. Which has severe airway obstruction at rest, managed with nasal CPAP, comes for emergency laparotomy. So we all know Pierre Robin have two of those main concerns where they have difficult mask ventilation just from the anatomy, as well as difficult laryngoscopy where we don't have a very good view. So all of us have managed this difficult scenario in a controlled situation where we have all our equipments ready. We go with plan A, plan B, and plan C. The trick with this case is we are adding a third part where we have intestinal obstruction and a full stomach. So we managed taking that into account to see how we can reduce the risk of aspiration, at the same time not the risk of decrease the risk of losing the airway, since as most of us manage difficult airway in these children with spontaneous ventilation with the sevoflurane as a background anesthetic, and we can do either attempt to look at DL or...
So your basic concerns are the difficult mask ventilation, laryngoscopy and full stomach. Added to that is the small child, right?
Yes.
So very small baby, which we are not always familiar with. Dr. Tan, can I just ask you, this is an emergency, right? So how your assessment is quick, and how effectively you can identify the different difficulties in this child as far as airway management is concerned?
For me, I think this child is a Pierre Robin syndrome. So Pierre Robin babies or Pierre Robin children have got a small jaw and probably receding as well, and the tongue may have glossoptosis. And so airway obstruction is definitely an issue with them. And GERD, which is reflux, is a problem, but this patient actually has a small bowel obstruction, so definitely that risk of aspiration is going to be a concern here. So first of all, of course, we need to make sure that the patient is otherwise fine hemodynamically, and whether the patient has got a Rouse tube, whether the stomach is being emptied. And even then, of course, the risk of aspiration doesn't actually go away. So for me, I guess there's a problem of mask ventilation, so I may inhale the patient down, quite pressure if it's okay, and prepare difficult airway equipment. We do have a video laryngoscope, so I have to make sure that the patient, I can maintain ventilation by...
So basically your assessment in a quick way, but not missing any points, will lead to the selection of proper plan and equipment,
yeah, that's
right?
right.
So then we'll go ahead with the anesthetic management.
Yeah.
Again, I'm coming to Dr. Madhankumar. What is your primary plan? For you have been the primary person who has taken care of this patient. What is your primary plan for this patient? Always in a difficult airway, we look at primary plan and backup plan. And also, of course, we have the rescue plans also in our mind. So what's your primary plan?
The primary plan is, as we all know, the oxygenation is the primary concern, and the intubation is the secondary. We don't want to lose oxygenation. So our plan for this case to have the relieve the airway obstruction, we use the supraglottic airway. The only difference in this case is we wanted to use it awake technique. Awake supraglottic airway has been described in many case reports in adults, and there have been several case reports in children and also neonates. So we decided to use an awake supraglottic airway and try to modify it with local topicalization. So we had a couple of techniques of how to topicalize in a neonate just a pharyngeal wall to tolerate the supraglottic airway. The way we used it, either it is a jelly technique where you can just put it in a finger and have the baby suck on it, or just reach the pharyngeal wall and just topicalize with your finger. Or the other better way is to have the jelly put in a pacifier and put it in multiple holes and have the baby suck on it for 10-15 minutes. That kind of topicalizes the pharyngeal wall, and they tolerate the supraglottic airway pretty well, maintaining spontaneous ventilation, oxygenation, no anesthetic on board, no gas, no sedation, and then use the intubation, fiber optic intubation through the SGA technique. Still then, we don't use it completely awake. Once you are happy with the placement of the supraglottic airway and the oxygenation and the good view of the glottis through the fiber optic, then you can use the modified rapid sequence to secure the airway.
Before we go ahead, Prabhavati madam, can you just tell me if you would like to do it in any way differently, or if in case we do not have the supraglottic device, what else you would have, how else you would have begun with?
This peri-Robin syndrome, actually the children, I thought that the mask fit can always be adjusted. I come from a time when we didn't have all the devices of modern times, so probably we always saw that the mask fit was good enough. We held the baby, induced the baby with the mask all right, so that they don't protest when we put any device or anything. And of course the topicalization. And I had done many direct laryngoscopies. I found that in the newborns, the airway can be secured without a difficulty, but I don't advise it anymore because we have wonderful supraglottic airway devices through which we can intubate. But the one concern in these cases can be that the nasogastric tube has always to be in place when they are induced. And mask ventilation, though it looks out of fashion, it is better to verify whether the child, when your bag is moving with the respirations of the bag when you hold the thing. This probably when you introduce a supraglottic airway device, sometimes you may not be able to really fit the device properly when there is a lower jaw malformation.
So, Dr. Dilip Pawar, sir, how would you have managed this case?
I like to assess the airway. All peri-Robin syndromes or sequelae are not the same. They don't have the same airway difficulty. It depends on the size of the mandible, how receded it is. That means what is the space, intermandibular space or intermandibular space available for the base of the tongue to be displaced during laryngoscopy. So if it's too small, you can't displace the base of the tongue, you can't intubate. But if you approach in the lateral positions where you don't have to actually press the base of the tongue, or you can visualize the larynx. That's how the peri-Robin Bonfield was designed for a lateral approach of approaching the airway. But then with new devices, supraglottic devices, it's much easier to put a supraglottic device after a jelly or cream and then induce the child. But because this child has got a full stomach and they are more prone to having a low, also opposite sphincter are slightly relaxed, I'll prefer to empty the stomach in an empty child, an awake child, and remove the catheter out so that the esophagus is still competent enough. It's not incompetent. The catheter makes it incompetent. So the chance of regurgitation is very high.
Thank you, sir.
Okay. You have any opinion, Dr. Deepak? You want to add any comment?
No opinion. I'm just holding the mic. But then, since I have the mic and you've given me the opportunity, just like to say that interesting to know that this technique was published in 2013, and I have my guru here and Professor Arora somewhere in the audience. We were doing this topicalization with little finger neonates very often before we would do an airway intubation, 99, and it's been published in 2013. So probably we missed the idea. Thank you very much.
I think Dr. Prabhavati wanted to add something, ma'am. Did you want to add something?
I was just post Dr. Pawar's comment about removing the nasogastric tube. When you, Yes, what all you said is absolutely right. But what I found is when we removed the nasogastric tube during the inductions, whether we ventilate or the child bucks, there's a lot of air that goes in, and repeatedly we may not be able to introduce. So I wonder whether we ought to be removing the nasogastric tubes when we are dealing with difficult airway devices. Keeping them in situ, I feel that offers some safety during handling of the child with any other supraglottic airways or video laryngoscopies or anything.
So till now, yes, we are sure this patient has a difficult mask ventilation. It's an emergency. Rales tube might have to be removed. The child has full stomach, but still we need to go ahead with the surgery. It has to be done. So intubation obviously is the choice. So how do we intubate? And we'll just see the video, and I think Dr. Sathyamoorthy will have his comments. Dr. Madhankumar will have the comments while the video is going on. Video, please.
This patient has already been topicalized with the pacifier 10-15 minutes, and as you see, the baby is awake completely with no sedation or anesthetic on board. We are maintaining good airway exchange, a good chest movement, and now the next step is to confirm, even with LMA having good ventilation, the proper visualization of the glottis to the fiber optic can be still not optimum. So the next step is to confirm the glottic opening before we proceed with the rapid sequence.
Yeah. Next. Yeah. Start, please. No, video, previous video. Second video. Yeah. Yeah, this one. Start it.
Okay. Just confirming that, see if we have a good glottic opening. I think that's the best we're going to get. Once there, we can stop and use your IV induction technique for rapid sequence, whatever you prefer. We just used propofol. We can use a paralytic if we have to, but we need to have at this point before introducing the tube, we need to have a good anesthetic on board to increase our success rate. Once you go through the glottic opening with awake patient, then you can induce a lot of trouble with coughing, bucking, and everything.
So with this, yes, we have successfully intubated this child. Surgery goes on, and Dr. Tan, would you just like to comment on the extubation? Dr. Tan?
I think extubation.
Yeah. Extubation.
Extubation in this patient will have to be taken with some care. So first of all, you have to discuss with the surgeon and to see how well the patient is, whether the patient is extubatable or if the patient is septic, then the patient may need post-op ventilation. And then if everything is well and the surgery is not prolonged and fluid management is good and you deem that the patient is extubatable, then you need to decide whether his ventilatory parameters have returned and adequate before you even take the tube out. For this patient, then of course you have to decide where's the best place to do it, and probably the OR to me would probably be the best place. And for me, I would make sure that the patient is breathing well and fully awake before I would even take the tube out. And I need to make sure that his muscle paralysis has been fully reversed. And of course, even then, I will need to make sure that there is equipment that is still around, difficult airway equipment, and not stashed away in the storeroom since the op is completed. So we still need to make sure that difficult airway equipment is still around in case we run into problems at extubation. And I think having the LMA is still very useful in case you lose the airway after extubation. The LMA can be a rescue device. And of course, make sure the patient is well oxygenated before we even take the tube out.
Yeah. Failure to plan for the failure is one of the leading cause of complications when we talk about difficult airway. Yes, failure is anticipated. We must have a plan for that. Same thing applies to extubation as well. Elsa Madam wants to, or the chairpersons want to make any comment? Nothing. Okay. So we have done with this first patient where we had this 2 days old period. Sorry, audience, somebody wants to make a comment.
Hello, yeah, I'm Dr. Suraj from Rainbow Children's Hospital, Bangalore. We had 3 cases of period means 2 of them were preterm neonates. So here the concern is the fiber optic scope will accommodate only a 3.5 size tube, that too snugly. So if your requirement is of a 2.5 or a 2 size tube, then we are in trouble there. So the first case we did struggle. Second case it was posted for a glossopexy. So we used a retrograde intubation using a urological guide wire. We had a poster on that yesterday, and it was a smooth intubation. It roughly took about 13 minutes, and the airway was secured. We did use a supraglottic airway before that to maintain the oxygenation, and we passed the guide wire and railroaded the tube over that.
Thank you. Thank you for your comment. I just have just something to add. For my hospital, we have a 2.2 mm fiber optic scope, but not every hospital will have one. And I think most major companies are producing scopes of 2.5 now, no longer producing 2.2. But the ENT surgeon actually has a nasal scope. The nasal scope is much shorter than our fiber optic scope, but it will be enough to intubate a very young child. So they have a 1.9 that is quite short, but enough for intubation. So if you have a neonate and you want to do fiber optic, you could borrow the nasal scope from the ENT surgeons.
I saw this poster yesterday, and it was quite innovative actually, but I thought, and we've done this a couple of times, if you don't have the adequate side of scope, you could, take the scope to the glottis, doing the same thing what was done in this case, and pass a guide wire, and then remove the scope and use it over the guide wire. So same thing. So you don't push the scope way down into the trachea. Keep it to the glottis, and we've done that often. So that's one solution, and maybe you could have tried that, because it was well managed, yes, the case, but then, we've gone through these guidelines, we've gone through this literature. Cricotracheal puncture can be very tricky in neonates. So that's one word of caution I'd like to say. So I thought safer would have been to sort of, try this. Yeah. That's my opinion. Thank you.
Dr. Padmanabh, just waiting.
If I can just make a comment on this, the problem is that the pediatric fiber optic scopes don't have a port for a guide wire.
2.2 has. Of course,
so that all depends on the scope.
This is absolutely. It is possible only when it has a suction channel. Certainly. So thank you.
Yeah, Dr. Padmanabh.
I have one comment. Instead of putting an high gel for an awake patient, LMA for an awake patient, that invariably the child is struggling, and the more chance that it'll put the omitus out. One. Second, number 2, the patients with awake patients with putting an LMA can also cause an laryngeal trigger or posterior laryngeal trigger and cause a laryngeal spasm. Probably we can put a simple oropharyngeal airway, deepen the child, probably then convert into an LMA and C for another thing. Before relaxing the patient, probably that can be a better way out rather than pushing the LMA directly in a awake child.
We'll discuss later. So, sir, you want a last comment, please? Yeah. We'll move on to next one.
We used to conduct cleft palate cases in such patients, and my experience that we should take tongue stitch before extubation. Usually, routinely, these patients may be having respiratory obstruction due to tongue fall. And if we take the tongue stitch, and which can be removed later in NICU or PICU, it will be better.
That's perfect, sir. So we have covered some of the suggestions are related to elective cases, and there are many suggestions about the anesthetic management. Yes, as long as it is within the acceptable guidelines and the standards of maintaining the oxygenation, avoiding too many attempts, and having a reasonable experience and proper selection of equipment, all are right. So we must respect the patient's safety first, and we will move on to second patient. Thank you.
The second case is a post-tonsillectomy bleed, a 5-year-old, history of obstetric sleep apnea, and the tonsillectomy was done 1 hour back. There was profuse bleeding seen in the post-operative from the tonsil bed, and surgeon has to take in the patient for examination and require intervention. What are the anesthetic considerations in these patients? Dr. Serpil?
Now we have a 5 years old and just operated tonsillectomy. He is bleeding. We should consider hypovolemia, or if he is awakened very well, full stomach because of bleeding, and also maybe he has eaten. And also we have difficult airway because of maybe obstructive sleep apnea or just operated patient. So when we take the patient into the room, the child usually wants to be head up position. We don't want to change the position and try to intubate him like this. And all our aspirators and this is bleeding, so electrocautery should be ready. We will share the airway. The airway will be in bloody position, and our all equipment should be ready. And also, we want to protect the airway before before the child vomits. Before tracheal intubation, we should not positive pressure ventilation should not be done. And if it is possible, less than 5 years old, we can sedate the child with maybe Precedex, and awake intubation is the ideal position. But if not younger children, we can choose the SRI with succinylcholine or rocuronium, preferably. Precedex is a good sedation agent in this setting. As soon as we intubate, electrocautery and also the bleeding should be controlled, but sometimes the bleeding could not be controlled, maybe coagulopathy problems, so we should be aware of these. Video laryngoscopy may be a choice. Our equipment should be ready, but the equipment should be what we are familiar with. This is not the time to experience something new or fancy equipments are all around. What you feel safe is the equipment of choice in this setting. Regarding extubation,
no, we will come to the extubation. Dr. Digant, what are your comments on the intubation, the initial management of this airway in this child?
How?
Dr. Digant. Yeah.
Sir, this child has mainly three problems. Number one, we usually get this kind of child very irritable.
Yes.
They are very irritable and they are non-cooperative. That is one problem. Second problem is usually they come with some amount of hypovolemia. She said rightly. And third is full stomach. So we have mainly these three problems. So at the very beginning, we should try to let the child sit forward and expel as much of blood possible from his mouth. And secondly, we should try to place an IV cannula and try to infuse some fluid. Okay. So that we can correct some amount of hypovolemia before inducing this child. And thirdly, I think we can go for rapid sequence induction with frequent pressure, succinylcholine or rocuronium. That way.
The need for monitoring the hemodynamics is very important, because blood loss cannot be measured, and a hemoglobin measurement would be most important before we start the case. That's what we think. And in this case, what would be the plan for extubation, Dr. Deepak?
Now, if given a situation where the intubation wasn't difficult to begin with, and I think, and the surgeon has done a good job of securing the bleeding. So I would think that this would be rather a low risk extubation situation over here. I am not sure how severe the OSA is. I mean, if you're giving me a situation where the OSA is purely because of tonsils, not because of the weight, then I suppose that problem is out. And if we have managed our opioids well, extubation should not be an issue, is what I would think, if intubation hasn't been a troublesome one to begin with. But I have a different question. I mean, does that answer your question?
Yes.
But I have an observation here. Inhalation induction in sitting position, I would rather go against it actually. I would rather induce this child in a head-down position and rapid sequence. So what's the view over here? I mean, it's been flashed on the slide that sitting position. Sir, what do you think? I would rather have a head down and prepare, do the suctioning and then go for a rapid sequence induction.
Yeah, whatever you do, you have to secure the earliest and fastest time. So inhalation doesn't allow you that. It delays the induction time. So you are exposing the airway for regurgitation and aspiration. So basic principle is do it fast as you can. So intravenous induction and sucks is the right choice. Doesn't make much difference.
Dr. Deepak, you said this obstructive sleep apnea, if the tonsil is the cause, it will be like almost removed at the end of the surgery, right? Does it happen immediately?
No, what I meant was that it won't happen immediately. Obviously, the cause has been removed, but then there is no difficult intubation per se now. That's what I was hinting at.
Yeah.
I mean, there is no difficulty in glottic visualization per se.
Okay.
So it's not something that where you're going to be having difficulty in intubating the child again if some airway difficulty arises. So that's what was my point. Unlike the first child, where you could be considering using an airway exchange catheter or having your plan B ready. So here I would think that it'll be a smooth sailing, given the situation that you've. Of course, after tonsils have been removed, the child will recover from obstructive sleep apnea gradually, as the literature says. Thank you.
Madam, do you add anything, points about obstructive sleep apnea? Prabhavati, madam.
Could you please repeat what you said?
Would you add any points in this case, as it is a OSA? Yes, Dr. Deepak sir said that removal of tonsils could give the airway could be roomy, but then still some amount of edema will be there, and there's a dicey situation where you do not want the patient to be apprehensive, irritable, and so you give sedation, but at the same time airway could be a problem. So what do you say to this?
I'll just like to interject here. If you're saying that a patient would need observation, so maybe certainly it's not a daycare surgery. That's one thing.
Once post-tonsillectomy bleed is seen, it shouldn't be.
Should be observed for a longer time than usual. That's what I'd like to add. Thank you. Sorry to interject.
No, it's fine. Extubation would be the most ideal because it's a tonsillectomy, and we would not like to hold the patient on for days on, though this patient would. But if you have obstructive sleep apnea is a consideration with huge loss of blood loss. Extubation at the end of the surgery may not be always possible in these cases. If I am realistic, I don't think, if I were to be doing, I would not consider this child to be extubated on the table. I would rather have him in the intensive care, at least for a day, to extubate and the edema to subside. Because so much of handling, cauterization, everything goes on, and all no holds barred suctioning, and so.
But the point is not difficult airway being the cause of extubation. The point is hemodynamic instability. So that's how I would, I like to say. So the cause of delaying extubation is not the airway per se, but the surgical.
No, the multiple factors which go.
Thank you.
Right.
Yes, sir, please.
The question should be posed, once you insert the laryngoscope blade, the mouth is full of blood. What do you do? Panelists. You put in your yank hour. The blood is accumulating faster than your yank hour can clear it. This is a real case. This patient died in our hospital.
Absolutely. So you do a suction immediately, right?
I'm sorry?
You suck out the blood, whatever you see in front of...
it's filling up faster than your yank hour can remove it.
All right, then I'll go by what Dr. Pawar said. You secure the airway as early as possible. So if you're telling me that suction is, the bleeding is outrunning the suction part, then, you just have to be quicker than the bleeding part of it.
No, this is an arterial bleeder. It's not common. But if it's an arterial bleeder and that child's not very hypovolemic, we're going to have quite a lot of blood filling that small oral pharynx faster than your Yankauer consuction. So Kumar, what would you say? Is this an oral exam question? But these are true life situations, and this is really the essence of these kinds of cases because they happen infrequently. And if you don't think about how to manage and go down this algorithm, one day you could get caught because everything you said so far is correct, but you have to really push it to the limit.
So the assessment about the arterial bleed, like what is the duration after the surgery? Is there any way to suspect this rare arterial bleed beforehand? You said
well, he wasn't bleeding much until you put in the laryngoscope, and that scab probably came off. So now it's filling up faster than your Yankauer. So come on, he's dead if you don't do something.
So what I'm going to do is, I got your point, and I think what I will perhaps do at that situation, I'll pick up perhaps a Magil and whichever foci is bleeding from, try to put a swab over there or a small ball of peanut swab and try to do the intubation at the same time. I mean, it's sounding difficult, but then that's what I have to do, I guess.
Okay.
Yep.
So the first thing is you would have a second Yankauer, a second suction. But suppose that doesn't work. You turn them on the left side.
First, yeah.
And then any blood will run out the bottom of the mouth and you can intubate from the right commissure. The only problem is, which happened to me in the recovery room with a child like this, was it was on the right side. The bleeding was arterial coming from the right side. And we were only lucky to have a 120-degree clamp. We could jam it inside the mouth and stop the bleeding and intubate the child because he wouldn't lie flat. That's the other hidden clue if it's already going on. And he knows he lies flat, he can't breathe.
Yeah, I think...
Can I make a quick comment too? I actually have a case exactly like what Professor Lerman has described in our hospital when we had post-tonsillectomy bleeding, arterial bleed. Patient was barely conscious because this is secondary bleeding, came back from home. HB was already 4 or 5. Came into theater, so bleeding a lot. We have lots of Yanka, lots of people trying to resuscitate. And the life-saving surgeon came in and put his finger on the bleeding point where we can rapidly induce, and we had a large bore RV already, and then intubate. So I think this is the most important part when you have a bleeding tonsil, have your surgeon there and he know how to stop the bleeding. And we have this kind of bleeding now, I think because we are using more co-beta and they have secondary bleeding after surgery. So. Yeah,
okay.
That's my humble suggestion.
Thank you. I think
Can I just make a comment? We have discussed the airway in detail, but what about the full stomach? What about the Ryle's tube to be passed to remove, empty the stomach? That's an important thing I feel should be mentioned in this sort of a discussion.
Actually, I think they said suctioning out the blood from the stomach is important. The start itself.
Yeah, so putting in a Ryle's tube is very important.
Sir, last one comment and we'll move on to next one. Please, sir.
Mine is, if I had put a 5 tube in the morning, 5 tube will not go in the evening. Second,
yes.
So you have to have array of tubes and better to get 4.5 or something like that, lesser tube, and that's what because of the edema of the larynx.
So that's that's a part of preparation for a post-tonsillectomy bleed, having 2 suction in your OT and then having a tube sizes, 1 size lesser than what was done in the morning, and having it ready there so that you can use it. And they mentioned that you have to keep 2 sizes of all the endotracheal tube that's required, because as was said, the bleeding would cause blocking of the endotracheal tube and you need to have a next tube ready in place. Thank you, sir.
So now we will move on to the third patient. This is again a 2-year-old child weighing 14 kgs, presents to emergency department with complete airway obstruction. So here we are in a most dangerous, the red zone. Unresponsive oxygen saturation cannot be obtained and has got a generalized swelling which is sparing the neck. Neck is free, only the face is edematous, and intubation and mask ventilation and even supraglottic airway ventilation has failed. So what to do? Dr. Serpil, can you open the discussion? What you would do?
Now, this is a very difficult situation, so we have to go for invasive airway access if we are capable to. But if we have ENT surgeon with us, it will be excellent. And we will go for invasive airway access for this one, for maybe transtracheal.
Transtracheal approach,
yes.
You want to go, okay?
Cricoid thyrotomy, maybe the first choice.
Okay, Dr. Sir, Dilip Pawar, sir, can you just say what would be your opinion? How do you go about in this critical life-saving situation?
See, this front of neck approach is the only way, because we don't know how much edematous the larynx is and how patent the airway is and how much edema the intraoral cavity has. So it's going to be very, very difficult in this. So because it's already hypoxic and unresponsive, we should act very quickly and very smartly. Because the primary goal of airway management is maintain oxygenation, not allow the patient to become hypoxic. Because failing to put a tube doesn't kill the patient, but not able to maintain oxygenation during airway management kills the patient. So I'll go to front of neck approach, and it's less than 2 years. So it's a transtracheal is a right choice, but it's not out of danger, because it's very easy to go through the esophagus or vertebrae if you're not very careful. It has to be very, very expert hands. Cricothyroid is not the right choice in this age group, because cricothyroid membrane is not horizontal to the trachea, and anatomically is slightly slanted. If you see these photographs, the larynx in the previous talks, you can see a small breeze through the glottic opening, and that is the cricothyroid membrane looking at you. So if you put a needle through this in a small kid, or less than 5 years, that needle is going to come through the glottic into the pharynx. So it's transtracheal is the right choice.
Dr. Deepak, you want to have any comments about how we go about initially?
I quite agree with the situation, because you've painted a scenario where child is completely obstructed, and the only thing is the problem here is that how do we ventilate? And we can't go for jet ventilation, because you've given me a situation where the upper airway is totally blocked.
Now, is there any maneuver or any way you can still try to open the airway and maintain the patency to the extent possible as the preparations for the surgical acts are underway? Because if it takes much time, the child will suffer a hypoxic damage. So even though initially it is not possible to ventilate, any other maneuvers or any other change of equipment you would like to consider?
Oh, we can just go for a high flow oxygen from top, and just hope that it does the job. Yeah. While the needle cricothyrotomy, cricotracheal tracheotomy does its work, and ENT surgeon starts his job. That's what I would do.
With this situation, I would think that the call for the anesthesiologist to intubate would have taken long. I mean, if it is on the table, then we are ready. But if it's happened in the casualty and there's no anesthesiologist, they call you in as a specialist, airway specialist. By the time you go, there is disaster. So surgical airway could be the only way to go in. And like Sir said, high flow oxygen to be given through nasal. And that could, keeping our fingers crossed, would save the child and our day also.
Dr. Digant, you have any comments on this?
We have to go for surgical airway, but
okay.
Preceding that, we have that crucial moment. So we must be able to try to maintain some amount of oxygenation.
Okay.
So we have to continue with nasal oxygenation. We must continue with nasal oxygenation. Then we can put one either supraglottic device. In my case, I would prefer to put an iGel of his size, and I'll try to ventilate with bag mask, giving some CPAP, and at the same time I would like to put a gastric tube so that some amount of depression of the stomach, may be helpful for...
Suppose, okay, that's if the neck is free, you get ready for the surgical access or the percutaneous. Usually at this stage, obviously surgical is not very advisable. The needle one is not indicated. It's surgical, which is better if possible. Because we also had a patient left palate repair. It was not the same way, but the child had a massive tongue swelling at the end of the surgery. I think about less than a year-old child. Very significant, very massive tongue swelling. We were not able to ventilate, not able to see anything. So that day it was lucky the maxillofacial postgraduate student, she did the tracheostomy and saved the child. So, but it doesn't happen always. So invasive technique is important. In case the front of neck is not free, Prabhavati madam, what can we do? This is following her experience and...
This is all we talk about, always having the transtracheal needles and all. But when the front of the neck is not free, you have an angioneurotic edema with the swollen neck. I cannot offer a solution. I'm only looking at somebody to offer a solution in such situations, because I faced real situations twice, and I admit that the surgeons could not help because they wouldn't like to go through a neck swelling, and here probably everybody is so stunned in these kind of situations. They look to us that we will create miracles and save the airway, but then I can't cut open the front of the neck and go in, which a surgeon has to do. So I'm also looking for a solution, Dr. Raveendra.
So now that Prabhavati madam herself has said that, she's looking out for a solution. Audience, anyone who has experienced, somebody or the other, younger, old, senior or junior, would have experience. If you had a solution, could you come forward and give us an idea of how it could be done, if at all we come across such a situation?
Actually, I may make a point here. Is that, Chair Lady? Is that okay?
It's allowed, sir.
Yeah.
I'm asking you to.
Thank you. Actually, this is a real practical issue. We talk about this, no, you cannot intubate, cannot ventilate situation, and this is where you need a surgical airway. But how often do you experience this in your lifetime, or have you done it? And is it really easy to identify the cricothyroid membrane in a child like so, whose trachea may only be about 1 centimeter or 2 in diameter? So even a surgical airway is sometimes impossible in this very difficult situation.
Yes, sir.
So what is the solution? I think there are, as ma'am says there, that I'm also looking for a solution. I think today we have non-invasive tools, and we were talking in the airway sonography yesterday that when you have a patient like so, before you perform any intervention, and as Dr. Pawar mentioned here, that these cricothyroid membranes in these small children are not where you think it is. It's usually much more higher than, and closer to the mandible. So if you have a non-invasive tool like a sonography, you perform an ultrasound, you know exactly where the cricothyroid membrane is. So my advice to every anesthesiologist here is that as part of the protocol, and this does not come in your recommendation in the Indian Society I read that, or any other society recommendation where they say that you should use a sonographic mapping of the cricothyroid membrane, put a mark there and do whatever you do, whether you're doing a gas induction, whether you're doing a topicalization, or whether you're looking for doing a cricothyroid puncture. I think that would be something that's ubiquitously available. It is something non-invasive, just takes a few seconds, and you should be able to do that. So I would suggest that may be a good option in that situation.
Thank you. That's true, but the ultrasound assessment of the airway is becoming an important part, particularly for identifying the cricothyroid membrane. But in situations like this, which arises out of blue, almost like the child has developed anaphylaxis, and you wouldn't have done anything, any assessment. Yeah, last comment, that's all. So now only comment is on the rigid bronchoscopy, is it going to be useful?
Yeah, I'm afraid we have one more lecture after this, so we'll have to stop. So just to summarize, I think you've got 3 of the most horrific cases which are very real, and hopefully but I'm sure all of us would have faced at least one of these situations, if not all 3. Well, the take-home message from what I could say is just the query about, I think you mentioned, Joe, that you might apply cricoid pressure for your first case. Did you, I think that is something that, it's questionable whether one do it or not in a neonate. With the bleeding, upper bleeding, as I said, the Ryle's tubes don't help because you can't suction out. But certainly, I think the point made was you can't have just one suction catheter, suction apparatus, but at least two. And you don't use suction catheters, but you need a Van Cow suction for massive bleeding and possibly intubating them in the lateral position. And the third one, of course, about how do you locate the cricothyroid membrane. And of course, thank you very much for your comments about ultrasound.
I just want 15 seconds, please.
Yeah, the ultrasound that, if it is available, use it. Yes.
I think there is a discussion about topicalization of the airway, and this is something I think everybody should be aware of this. We haven't discussed this, I'm not an airway expert, but I have a lot of experience in this. People think topicalization of the airway is very innocuous, that it does not lead to any airway problem. I have had topicalization myself, not because I have a difficult airway, but I have volunteered in a study to do topicalization, and then they measure things. If you do topicalization in an obstructed individual or who's having difficulty stridor, it may cause total obstruction. Remember that. So topicalization of the airway is not as simple as we think it is. And with due respect to Dr. Sathyamoorthy, if I saw your pictures, the video, it looked like the child was really struggling. Now, it may be because of the airway per se, but the topicalization in itself in some of these difficult patients may make the airway obstruction or the difficulty worse because of discoordinate activity of the glottis. This occurs not because of airway issues or the muscles, but is the discoordinate function of the vocal muscles, and therefore the vocal cord goes into some kind of a discoordinate closure. So this is something I would like everyone to remember.
Okay. Thank you very much, Dr.